Hello everyone. So we are continuing with musculoskeletal causes of limb. Table is 1 to 3 is acute painful limb and chronic intermittent limb infection, septic arthritis, osteomyelitis of hip or spine, transient synovitis, trauma, accidental and non-accidental malignant disease, leukemia, neuroblastoma. Chronic intermittent limb is developmental stage of the hip, talipes. Neuromuscular will be cerebral palsy and JIA, 3 to 10 years, transient synovitis, septic arthritis, osteomyelitis, trauma and overuse injuries, pertussis disease, acute JIA, a malignant disease, leukemia, complex regional pain disorder, and chronic intermittent will be pertussis disease, chronic neuromuscular disorder, Duchenne muscular dystrophy, and GIA and tarsal coalition. 11 to 16 mechanical trauma, overuse injuries, sport injuries, slip capital, femoral epiphysis, avascular necrosis of femoral head, reactive arthritis, GIA, septic arthritis, osteomyelitis, osteochondritis, dissections of the knee, bone tumors, and malignancy, complex regional pain syndrome, slipped capital, femoral epiphysis, chronic GIA, and tarsal coalition. Transient synovitis contrasts with clinical features of transient and septic arthritis. Onset of transient is acute limb, non-weight bearing, acute onset, and septic arthritis is non-weight bearing. Fever is mild, absent, and septic is moderate or high. Child often looks well, and septic the child looks ill. Hip movement is comfortable at rest. Limited internal rotation and pain on movement. Hip held flexed. Severe penetration both on any attempt to move joint. White cell count is normal and septic is high. Acute phase reactant ESR would be raised in septic and slightly increased in normal. Ultrasound of fluid in joint both. Radiograph is normal and widened joints with or normal septic arthritis. Management is rest analgesia, joint aspiration, septic arthritis, and usually under ultrasound guidance. Prolonged antibiotic rest analgesia course resolves less than 1 week, approximately, and progressive very severe joint damage if not treated. Kosher criteria for differentiating septic for transient arthritis likelihood. Number one is score likelihood septic arthritis 3%. Number two, a point is given for each of the four criteria. Non-weight bearing on affected side, the ASR is more than 40, fever is more than 38.5, and WBCs are more than 10 now. 40%, 93, and 90% are the scoring. An MRI scan, post-contrast coronal T1 fat saturated that demonstrate the enhancing synovium in the left hip, suggesting synovitis can be seen in both transient and early septic arthritis. They need to be differentiated clinical examination practice results. And this is Pertussis disease showing flattening with cirrhosis and fragmentation of right femoral. Capital epiphysis, left hip is normal. Now let's look capital femoral epiphysis as the spinal epiphysis of femoral head. Posterior inferior requires prompt treatment to prevent avascular necrosis. It is most common at 10 to 15 years of age and during the adolescent growth spurt, particularly in these boys and bilateral in 20%. There is an association with embolic endocrine abnormalities, hypothyroidism, hypogonadism. Presentation is with limp or pain in the hip or referred to the knee. The onset may be acute following minor trauma or insidious. Examination shows restricted abduction and internal rotation of hip. Diagnosis confirmed on X-ray. A frog lateral view should be requested. If there is high index of suspicion, X-rays are normal. MRI may demonstrate early SCP and which is slipped capital femoral epiphysis, where sometimes detect features consistent with the risk of slipping in the contralateral hip. Management is primarily surgical stabilization, and usually with pin fixation in situ. And prophylactic winning of contralateral size performed by some surgeons. Physiotherapy following stabilization is essential to optimize the range of movement and return to normal activities. Summaries regarding hip disorders, DDH, may be identified on neonatal and physical examination. Screening at birth and in 8 weeks, therefore, by detection of asymmetry of skin folds around the hip, limited induction of the hip, shortening of the affected leg or a limb or abnormal gait, transient synovitis, most common cause of acute hip pain or a limb, must be differentiated from septic arthritis. Leg calf pertussis disease is just school age children with hip pain or limb, and slip capital femoral epiphyseal dorsal limb or hip pain. This slip capital And these causes of polyarthritis, bacteria infection is septicemia. Causes are first is bacteria, septicemia, septic arthritis, TB, virus, rubella, mumps, adenovirus, Coxsackie, herpes, hepatitis, and parvovirus. Other mycoplasma, Lyme disease, and rickettsia. Reactive would be GIT infection, streptococcus infection, rheumatic fever, and inflammatory bowel disease, corn and ulcerative colitis, vasculitis, HSP, and Kawasaki disease, hematological disorders, hemophilia and sickle cell disease, malignant leukemia, neuroblastoma, connective tissue disorder, JIA, SLE, dermatomyositis, mixed connective tissue disorder, polyarthritis nodosa, and other cystic fibrosis. Now, arthritis presents with pain, swelling, heat, redness, and restricted movement in a joint. In the monoarthritis of acute onset, consider septic arthritis or osteomyelitis if the child is systemically unwell with fever, as urgent diagnosis and treatment is required. With infection, more than one joint can be affected, although single joint is more common. The cause of polyarthritis are listed. Reactive arthritis is the most common form of arthritis in childhood. It is characterized by transient joint swelling, usually less than 6 weeks, often of the ankle or knees. This usually follows or really accompanies evidence of extra-articular infection. Indirect bacteria, Salmonella, Shigella, Pylobacteremia are often the cause in children, but viral infection is sexually transmitted in both Chlamydia, Gonorrhea, Mycoplasma, Borrelia, which is Lyme disease and post-operative reactive arthritis are other causes. Fever is low grade, acute phase reactives are normal or mildly elevated, rexes are normal. Analgesic NSAIDs are required, and complete recovery can usually be anticipated. Rheumatic fever is uncommon in high-income countries but frequent in many low-income and many countries in this diabetes. Septic arthritis, this is a very serious condition of infection of joint space by bacteria fungi, as it can lead to bone destruction. It is most common in children less than 4 years of age. It usually results in notogenous spread, but may also occur following a puncture wound or infected skin lesions. Chickenpox in young children, it may result from spread from midriff and osteomyelitis into joints, where the capsule inserts below the epiphyseal growth. They usually only one joint is affected, particularly the hip, but also the knee and ankle. Beyond the neonatal period, the most common organism is Staph aureus. Other microbes include Streptococcus and Shigella. Influenza was an important cause in young children. Phytomerization had often affected multiple sites. Underlying and predisposing illnesses such as immunodeficiency and sickle cell disease should be considered. This is septic arthritis of the hip joint, marked tenderness over head of femur, swollen thighs, leg, head, flex, abducted, externally related, no spontaneous movement, pseudoparalysis, posture to intra, showing the courageous posture to reduce intracapsular pressure. Any leg movement is painful and is resistive presentation. This is usually with an edematous mom, acutely tender joint with a reduced range of movement. In an acutely well-febrile child, infants often hold their leg still, pseudoparesis or pseudoparalysis, and cry if it is well. A joint effusion may be detected in peripheral joints, although a sympathetic joint effusion may be present in osteomyelitis. Osteomyelitis is accompanied by marked tenderness over the bone. However, in up to 15% of cases of osteomyelitis, there is coexistence septic arthritis. Diagnosis of septic arthritis of the hip can be particularly difficult in adults, as the joint is well covered by subcutaneous fat. Initial presentation may be with the limp and pain after the investigation management. There is an increased white cell count and acute phase reactants and blood. Cultures may be taken of some deep joints, such as hip, is helpful to identify diffusion. X-rays are used to exclude trauma and other bone lesions. However, in septic arthritis, X-rays are initially normal, apart from widening of the joint space and soft tissue swelling. Further imaging options include MRI scanning or radioisotope bone scan may be indicated if the site of infection is unclear. And aspiration of synovial fluid should be done as soon as possible to identify the organs in culture as a definitive investigation. This also decompresses the joint and provides symptom relief. Antibiotics should be started promptly and subsequently adjusted according to the culture's results. A prolonged course of antibiotics is required initially intravenously. Washing out of the joint, surgical drainage will be required if resolution does not occur rapidly out of the joint is deep-seated, such as the hip. The joint is initially immobilized in its functional position, but subsequently must be mobilized to prevent permanent deformity. Early treatment of septic arthritis is essential to prevent destruction of articular cartilage and bone. And this is GIA. This is commonest chronic inflammatory rheumatic condition in children and adolescents. This vine is persistent joint swelling of more than 6 weeks duration, presenting before 16 years of age in the absence of infection or any other defined cause. Most children have a disease that's clinically immunogenetically distinct from rheumatoid arthritis. In adults, it has a prevalence of approximately 1 in 1,000 children, similar to epilepsy, with over 12,000 affected children in the UK and estimated over 2 million worldwide. There are 7 different subtypes of GIA. Each subtype and its clinical features are shown. Classification is clinical and based on number of joints affected in the first 6 months. Oligoarthritis up to and including 4 joints, polyarthritis more than 4 joints, systemic with fever and rash, psoriatic arthritis, enthesitis, localized inflammation, insertion of tendon and ligaments in the bone, often in feet, and further subtypes. Subtyping is further classified according to presence of rheumatic factor HLA B27 tissue type. Features in the history are gelling, stiffness after periods of rest, such as long car rides, morning joint sickness, and pain in the young child. It may be present with intermittent limb or deterioration in behavior or mood and avoidance of previously enjoyed activities rather than complaining of pain. Initially, there may be only minimal evidence of joint swelling, but subsequently there may be swelling of the joint due to fluid within it, inflammation in chronic arthritis, proliferation of the synovium, and swelling of the periarticular soft tissues. As the presentation can be indolent, especially in young children, in the most common forms, baseline investigations are often initially normal full blood count and inflammatory markers, negative rheumatoid factor, and radiographs. Diagnosis can be difficult. Anti-nuclear factor may be present in children with GIA, but can also be present in healthy children or during transient illness. However, in any children-wide joint pain, fatigue, or multi-system involvement, the possibility of the connective tissue disorder, GIA, or systemic lupus erythematosus needs to be considered. Long-term with uncontrolled disease activity, there may be bone expansion from overgrowth, which in the knee may cause leg lengthening or valgus deformity. In the hands, discrepancy in distal length, and in the wrist, advancement of bone age. If systemic features are present, sepsis and malignancy must always be considered if GI is suspected. Even if joint abnormality is not clear, referral to pediatric rheumatology is indicated as early treatment requires radically improves. Complications chronic anterior uveitis. This is common but usually asymptomatic in the early stages and if not detected and treated, can lead to severe visual impairment due to cataract and glaucoma. Oligoarticular subtype. The presence of HLA-B27 positive anti-nuclear antibody are risk factors for GI-associated uveitis. Regular ophthalmological screening using a slit lamp is indicated. Okay, this is subtypes onset of GIA, oligoarthritis, persistent for 9%, 1 to 6 years. Female male ratio 5:1, 1 to 4, maximum joints involved, knee, ankle, and wrist. Chronic extra-articular features. This is very good. Cable and chronic anterior uveitis, 20%, leg length is 20, prognosis excellent, and laboratory is in it, plus minus. Oligoarthritis extended 8%. And this is more than 4 joints involved after the first 6 months. An asymmetrical distribution of large and small joints, chronic anterior uveitis, 20% asymmetrical growth, prognosis moderate, and ANS plus minor polyarthritis, 1 to 6 years, male female 5:1, symmetrical large and small joints, joint arthritis, often marked finger involvement, cervical spine, temporomandibular joint may be involved. Low grade fever, chronic anterior uveitis, rate reduction of growth, prognosis moderate, polyarthritis, and it is rheumatoid factor is positive. Okay. In polyarthritis, it is no. In rheumatoid factor, if rheumatoid factor is positive, symmetrical, large, and often marked finger involvement. Rheumatoid nodules, 10%. sorry, it's rheumatoid nodule synthesis similar to adult rheumatoid arthritis and prognosis poor. Rheumatoid factor positive for long term. Systemic cancer is 9%, and 1:10 male female ratio 1:1. Oligoarthritis or polyarthritis may have aches and pains in joints and muscles, arthritis and myalgia, but initially no arthritis. Acute illness, malaise, high daily fever initially with some rank macular rash, lymphadenopathy, parasphenomegaly, sinusitis, prognosis variable to poor. Anemia, raise neutrophils and platelets, high acute phase reactants, and psoriatic arthritis 1 to 16 years, male female ratio 1-7%, and usually is asymmetrical distribution of large and small joints, dactylitis, psoriasis, nail pitting, and or dystrophy, and these are the extra-articular features. Okay, and this is chronic interior uveitis, 20%, prognosis moderate. Enthesitis, later arthritis, lower limb, large joint arthritis, initially mild lumbar spine or sacroiliac involvement. Later enthesitis, occasional acute uveitis, prognosis poor, moderate, and HLA-B 27 positive. Polyarticular juvenile idiopathic arthritis showing swelling of the wrist, metacarpal interphalangeal joints, and early swan-like deformities of the finger. And early swan-like deformities of fingers and joint contraction erosion. Chronic uncontrolled joint formation can lead to erosion of articular cartilage, contribute to limitation or joint movement and functional impairment. Joint destruction can lead to the need for joint replacement. Joint contraction is preventable with early diagnosis. This is chronic anterior uveitis, the one we talked about in JIA, and near infrared light photograph showing extensive posterior synecdoche, resulting in small and irregular. Growth factoring uncontrolled joint formation can cause abnormal skeletal growth. Overgrowth of the affected limb may occur due to increased blood flow accompanying inflammation. Joint inflammation can also lead to early fusion of the growth with infected limb, resulting in undergrowth. Both processes can lead to lymphatic discrepancies, which can result in mechanical problems such as scoliosis. Systemic inflammation diseases and steroids may also associated with generalized reduction in growth. Growth problems are largely preventable with early diagnosis. Growth will be a marked renal outcome, not least in an 80-year-old girl with JIA. For comparison, sister on the left is 4 years old. This can be prevented with very early optimal. Swollen left knee in juvenile is also flexion contraction of the knee. Macrophage activation syndrome, the most serious complication of systemic GA is macrophage activation syndrome, which occurs in 4 to 13% presentation of acute with continuous fever, reduction of erythrocyte, leukocytes, and blasters and normal clotting and multiple organ failure without early recognition from treatment is life. Constitutional problem, pneumochronic disease, delayed puberty, osteoporosis, multifactorial etiology, including diet, reduced weight bearing, and their systemic corticosteroids in delayed, reduced risk of dietary supplements of calcium, vitamin D, regular weight bearing exercise, and minimize oral corticosteroid. Sometimes bisphosphonate therapy is indicated in minor doses. Rare with modern treatment, but can present with proteinuria and subsequent renal failure and has a high mortality. Management of JIA has radically changed in last decade, and improvement in outcome is evident as long as children access appropriate care. Although GIA cannot be cured, early aggressive control of joint inflammation improves long-term outcome. Deformity, disability are much less common with current treatment approaching and early times. Medical management include NSAID analgesic do not modify disease, but helps release sympathetic flares. Joint injection, effective first-line treatment on oligoarticular GIA in polyarticular disease. Multiple joint injection are used as a bridging agent when starting methotrexate. Effective first-line treatments often use individual starting methods. It often requires sedation, residual anesthesia, and Knox, depending on the joint. Guidance with ultrasound or X-rays may be needed. Methotrexate early use reduces reduces joint damage. Methotrexate is basically effective in approximately 70% polyarthritis, less effective in systemic. Features of GI8 is given as weekly dose tablet liquid injection and regular blood monitoring is required for normal liver function and bone marrow suppression. Nausea is common. Systemic corticosteroid avoided if possible to minimize risk of dose suppression or osteoporosis. Pulsed intravenous methylprednisolone, often used for severe polyarthritis and is as an induction agent, may be life-saving for severe systemic arthritis, macrophage activation syndrome, cytokine modulators, biologics, and other immunotherapies. Many agents, anti-TNF alpha, IL-1, CDLA4, or IL-6, are now available and useful in severe disease refractory to methotrexate. They're expensive if given under strict national guidance with registries for long-term surveillance, T-cell depletion coupled with autologous hematopoietic stem cell rescue, bone marrow transplant option of refractory disease, selecting the most suitable medication remains problematic. Systemic onset JI, and these are case histories. What's left? Okay. Do case histories in a bit multidisciplinary team usually consisting of pediatric hematologists, specialist nurse, ophthalmologists, physical and occupational therapists, psychologists, and links to other specialties, including dentistry, orthopedics, is required to deliver optimal care. Physical therapy delivered by the specialist therapist is required to reach from muscle and bone strength and maintain the range of joint movements. Child is encouraged to take part in activities, subcontact sports, during active players. With optimal care, most children are managed as outpatients. The prognosis is markedly improved, and most children and families can expect good disease control and quality of life. If good disease control is not achieved, there can be significant morbidity from previous inflammation, such as joint damage requiring joint replacement surgery, visual impairment from uveitis, or fractures from osteoporosis. Joint replacement are now really needed in childhood, but are still needed in some adults with GI. Long-term children will need ongoing treatment into adult years to maintain remission. There is a significant psychosocial mobility with impact on school and employment. This is a diagnosis regarding school-setting disorders and transitional care programs are increasingly provided to facilitate the changes to adolescence and young adulthood to help young people learn how to self-manage their chronic diseases, live independently, and engage in shared decision-making. Now, GIE is a group of disorders causing arthritis of 6 weeks or more in a child or a young person, 6 years of age or younger window. I need to form a course, classification, clinical, legal arthritis, lesson for joints, while such as more than joint affected in the first 6 months, systemic urinary rash, radiating arthritis, and enthesitis, subclassified according to presence of rheumatoid affected HLA, B2070 type. Early aggressive treatment improves outcomes and prevents complications of joint damage, by contraction, limb discrepancy, blindness from uveitis. In spite of morbidity, more than half have active disease into adulthood. This is summary of typical symptoms: nocturnal awakening, leg pain, pivotal simple feature, normal child, growing pain, osteoid, osteoma, and anemia, bruising, irritability, and infection. Leukemia, lymphoma, neoplasma, and clunk on hip movement on neonatal and early infant screening, leg pain, and older infant, which is clinical features have older infant asymmetrical upper leg skin folds, limited hip abduction, DDH, febrile, toxic looking, irritability with nappy changing, restricting joint length, especially hip or limb movement, and septic arthritis or alternative sudden limb in an otherwise well young child, immunity restriction, transient synovitis, persistent disease, fever, erythematous rash, red eyes, instability in infant and young child, edema of hand and feet, mucositis, and cervical lymphadenopathy, Kawasaki. Irritability, fever, reluctance to move in infant and young child, stiff back, tripod sitting, endocytis. Multiple osteomyelitis. Joint pain, stiffness, and restriction is persistent joint swelling, GIA, loss of joint function, loss of joint range, and hip pain in obese and also related hip restriction, seat capital pulmonary epiphysis, and lethargy, unwilling to do physical activities, irritability, rash, highlighted edema, proximal muscle weakness, juvenile dermatomyositis. Constitutional symptoms, lethargy, arthralgia in adults and female, multisystem abnormalities, hematuria, facial edema, juvenile onset, systemic review, and synostosis are not showing purpose. This is most common vasculitis child presents with the purpuric rash over the lower legs and buttocks, usually associated with arthritis of the ankles and knees. Other features of abdominal pain which react with anemia. Inset systemic erythematosus. Yes, indeed, is rare trauma pattern with similarity condition back in organ. Children of Asian Black African Black Caribbean ethnicity are affected most frequently by conditions. It presents in adolescent female injuries such as malaria rash, often percentages. Pathological one is often common organ one like kidney, lung, or central nervous system. Serious complications. Blood tests show low white cell count, low compromise, and presence of antibodies and anti-double stranded antibodies. Treatment depends on severity of the system, which is from steroids to disease modifying rheumatic uh, drugs and recycling. Juvenile micromyositis is rare. The terms increase in malaise, progressive weakness, often difficulty climbing stairs, facial rash with edema with the bridge of the nose and malaise, and violaceous, neotropic deceleration of eyelids. Skin over the metacarpal proximal differential joints maybe have difficult pink and nail-fold capries will diet and tortuous. Muscle pain is a common, if not specific symptom, and arthritis within 30% cases. Respiratory failure, aspiration pneumonia may be life-saving condition described in next chapter. Autoimmunity, in these conditions are characterized by activation of immunity pathways and must be have findable underlying genetic mutations, usually involving the inflammation pathways use that point towards autoinflammatory disorders include the current episode of systemic inflammation onset in early childhood, family members with similar symptoms, elevated inflammatory markers during episode, negative infection stains, and absent of antibodies. Kidney disease need to be excluded. Clinical investigation include fever, rash, sinusitis, presenting as abdominal or chest pain, arthritis, and sterile meningitis. The major autoinflammatory development tumor necrosis factor receptor 1 associated periodic fever symptom traps, cryopyrin associated periodic fever disorder syndromes, CAPS, and hyperimmunoglobulin D syndrome, and periodic fever after stomatitis, pharyngitis, and adenitis. When the diagnosis suspected referred to specialist center is needed to establish diagnosis and provide treatment monitoring for development of secondary amyloidosis for genetic counseling if necessary. Genetic skeletal conditions, these are inherited abnormalities resulting in generalized developmental disorder of the bone, of which there are several hundred types. The usually result with reduced growth and abnormality of bone shape rather than impaired. Once it reduce with a pneumatic motion rather than impaired strength set floor, students and affected bones will spine for effective resulting in short stature. Intelligence is usually normal. Usually short stature intelligence is usually normal. Genetic testing is allowing better delineation of some disorders. So due to mutation in conclusion, the fibroblastic growth factor receptor gene, it is autosomal dominant disorder, but about 50% new mutation. Clinical feature of short stature for marked shortening of the hands, large head, fibroblastic impression of the nasal root. The hands is short and more marked lumbar. Those who develop high receptor sometimes happens. Thanatophoric dysplasia, they are more so we find it's our achondroplasia. The infants have a large head, extremely short limbs, and a small chest, where cervical medullary compression leads to early death. The appearance of the bones are extra characteristic. The importance of correct diagnosis of disorders that intracranial complex its inheritance is sporadic, may be identified on antenatal ultrasound. Cleidocranial dystosis in this autosomal disorder is an absolute part of all the clavicles and delaying closure of the anterior frontal of ossification of the skull. This child is often able to bring the shoulders together in front of the chest to touch each other as a polytrid. Such rigidity present intelligence is normal. So arthrogryposis, this is a heterogeneous group of congenital disorders in which there is stiffness and contraction of multiple joints. There may be an underlying logical abnormality or primary muscle disease. It is usually sporadic. Marked flexion contractures of the knees, elbows, and wrists. Dislocation of the hips and other joints, pelvis, equine waist, scoliosis are common, but disorder may be localized to the upper or lower limbs. The skin is thin, subcutaneous, tissue is reduced, and there is marked muscle atrophy around affected joints. It is usually unaffected management of this physiotherapist correction of deformities. Sorry, the skin intelligence usually unaffected management with physiotherapy. Physiotherapy and correction deformities is possible by splints, plastic cast surgery, what is in most rare forms. Osteogenesis imperfecta is a group of rare inherited disorders of type 1 person causing bone fragility, bowing, and frequent, frequent fractures. This is osteogenesis, loose sclera, osteogenesis imperfecta type 1, showing fracture of the humerus, osteoporotic bones, and fractured humerus type 2, showing shortened, deformed lower limbs. From gross and deformity of the bones, multiple factors. Autism is often considered an evaluation of unexplained factors and suspected child abuse. In the most common form, type 1, which is autosomal dominant, there are fractures during childhood and blue brain sclera, and some develop hearing loss. System is often considered in children fractures in addition to non-accidental injury. Bisphosphonates reduces fracture rates. Prognosis variable fractures requires looking to minimize joint deformity. There is where lethal form tied to with multiple fractures already present before birth. Many affected infants are still born. Inheritance is variable, but most of them dominant or due to nutrition. Other types of inconsistency may be minimal. Osteopetrosis marble, this rare the bones are dense, but the severe autosomal recessive disorder presents with faltering growth. Recurrent infection, hypocalcemia, anemia, and thrombocytopenia. Prognosis is poor. Bone marrow transplantation can be curative. Less severe abdominal form may present during childhood with fractures. Then this is Marfan syndrome. This is also an abdominal disorder of connective tissue. Severe tall stature, long, thin, this is rectodactyly, apex sensible joint, high arch palate, dislocation, the upper of the lenses of the eye, and severe eye. The body proportions are altered with long, thin limbs, resulting in greater distance between fingers and sole, lower segment, then forearm. Pubis, upper segment, arm span, made from the extended fingers is greater than the height. There may be chest deformity, scoliosis, major trauma, muscular deterioration of the media of vesical walls, resulting in dilated combinative root with valvular competition mitral prolapse and regurgitation. Aneurysm of the aorta made as said or rupture monitoring by echocardiography is required. We are done with it, but then let's move to case histories of GIA and we go on to GIA. Systemic onset GIA 2-year-old presented with high fever, a malaise, salmon color rash was presented with high fever. Investigation showed markedly raised acute phase reactivity. Shortly afterwards, he developed severe early articular joint disease. A diagnosis of systemic onset GIA was made on the basis of clinical presentation. He was treated with high-dose IV corticosteroid rapid improvement. This was followed by low-dose oral corticosteroid weekly methotrexate given by substitute. Patients family were brought to family was taught about giving his injections for treatment and physiotherapy and exercise and stretches to improve his joint range and muscle strength. He had further fears of his disease and was started on biological therapy. Tocilizumab given by monthly intravenous infusion on the pediatric day unit. Within 4 months from diagnosis, he had excellent disease control, and a year later, he was well but still on weekly methotrexate monthly biological treatment. He required long-term follow-up, including regular blood test and review by the pediatric rheumatological team. A Digo-articular 4-year-old girl was noted by her parents to be limping intermittently for several weeks. Her teacher at school, where she was quite less keen to play and not able to sit on the floor, study time. Her general practitioner performed PCAS assessment restricted. Observed she had limp in her right knee was swollen restricted. She was referred to pediatric government and pediatric rheumatology. Investigation showed that her basic blood test full blood count, physics were normal, but her ANA was positive. She has evidence of chronic anti-radiatus and system, and although she has no visual symptoms, uveitis was treated with topical corticosteroid, meso-injected corticosteroid, and visual anesthesia. She had physiotherapy to improve her joint movement and function. Family received information support from the pediatric rheumatology and multidisciplinary team. Her mobility, mood, energy improved, and she returned to normal activities. Serious school prognosis is excellent, although further flares of arthritis or uveitis are possible. She needs several. This case history demonstrates how prompt diagnosis and early specialist measurement reduces long-term morbidity. So the right knee, and this is cool. Thank you.